Yeah, tell me a little bit about yourself and why you started the foundation.
Okay. I'm a physician, and I went into medicine a little bit late. I wasn't really sure for a while whether or not I wanted to do medicine. I was very interested in public health, but I didn't know what angle. And so I worked up in Pakistan for a year, in the far north of Pakistan, in maternal and child health service after college. And that kind of made up my mind. I knew that I definitely wanted to do medicine and wanted to do global health. And so, is it recording okay?
Yeah, it's great.
So I came to medical school, actually did another internship for a year in refugee health in London, which is also another angle of low resource communities in the middle of a high resource potentially setting, but weren't people who weren't able to access the resources. So that was really informative. And then I came to Stanford for medical school, and while I was there was a Food Research Institute master's, which was economics, but development economics. And I discovered that that's really the kind of understanding that I wanted to gain, to look at health delivery systems and how to create them in a setting where there's no return on investment. You're just going to have a set grant or a set allocation from the government every year, and you're unlikely to really have a return on investment type of entrepreneurial setting. So I was interested in learning that, so I did a master's in international development policy during medical school, and I was able to go on a couple of medical trips while I was there to former Soviet Union, Georgia and the former Soviet Union. It was just at the time of the dissolution of the Soviet Union and the beginning of the formation of the CIS, and so that was really fascinating. Also in that setting, an area where there had been structure, and then the structure was gone, and now they were kind of trying to build something from the ashes of that, and some other trips too, and then in medicine, you get out of medical school, and then you have residency, which is about 4 years, and then you have to get some clinical practice. So it's about 6 years before I was able to go back to global health. And I was working here by then. I had come out of residency and started work here, and we have a sabbatical system. So I had my first sabbatical coming up, and I was looking back at the programs I'd been to before to see, could I go back to Pakistan, back to London, or back to the former Soviet Union, and kind of come at these programs with my new skill sets and better understanding and the masters and all of that. And I looked back at them, and they were all gone. Nothing was still in place. So the Aga Khan Health Service in the far north of Pakistan still existed, but all of the maternal and child health centers were gone. The girls' schools that were associated had been burned down, and there was nothing to go back to there. The system that I had worked on in London was also gone. They had done a fantastic study of how to help refugees access resources, and what were the barriers to care, and it looked like they were going to put those strategies into place. That didn't happen.
Was there any reason why they were no longer there?
So I didn't know, but that was part of the question that we started to think maybe we could ask. And so similarly, all the programs I'd worked in were gone. And so the question was, what is sustainability? And what are the barriers to keeping programs going? And what, instead of what programs exist that I can go and help and put a Band-Aid on some problem that's later going to go away, the assistance is later going to go away, rather than doing that, what could I do that would be sustained? And so that began the exploration, and we started to look at could we get at the underpinnings of sustainability. So our first year was spent looking at sustained health systems, and that's why we looked at Bhutan. Bhutan itself created and sustained a health delivery system for about 25 years and had made progress. They had reduced child mortality by 25% and improved nutrition, and really made some amazing advances with no medical school, 200 doctors in the country, but nobody knew how they'd done it. Nobody had studied the system, and nobody could say this is how. So we went to look at that system. That was the only one we could find that was a self-created, sustained, low-resource, developing country delivery system. And that was fascinating. And then after looking at that system and learning a great deal and studying some other pieces of the puzzle, we realized the question wasn't what is sustainability, but of the underpinnings of sustainability, of what programs need, what can we offer, what's here in Silicon Valley that are at our fingertips that we could provide to service providers on the ground in these areas. And we decided that assessments and outcomes were the two areas that we could potentially develop some tools in that would help because of where we are in Silicon Valley and who was working with us by that time. Assessments meaning like rapid knowledge, attitudes, and practice surveys and things like that, because we realized that communication tools, because we realized that one of the big barriers to sustainability is understanding what's really culturally acceptable. What do people think is the problem? What's been tried and failed? What's acceptable to the people in that area? And because a lot of programs that we'd seen fail, it was because it wasn't appropriate culturally. Like in Pakistan, the far north, they had built these cement latrines. I think I told that story. And the World Health Organization was hoping that this would cure diarrhea, which is the biggest killer up there. And that diarrhea was coming from fecal oral transmission. The people would go to the bathroom near the streams, and so would the livestock, and then the water would be contaminated, and so the fecal oral diarrhea bugs would be propagated. And so they thought if we build these dry latrines on the hilltops, that will cure the problem. But nobody looked at why do people go to the bathroom near the streams and what's culturally appropriate. And so they put these into place, and nobody used them, and it's because it's disgusting to go to the bathroom without a running water source in that culture. They don't have toilet paper, and it's just culturally appropriate to clean yourself with water afterward, after you use after you go to the bathroom, and that wasn't possible in the dry latrines. So huge amount of wasted money, and sort of a good window into what the problem was in a top-down health development type of system. So knowledge, attitudes, and practice surveys and assessment tools, and then outcomes tools. How do you know quickly enough what's working to target resources to working solutions? And in our communities, we had, of course, marketing tools to look at. Businesses always look at what's marketable and what's not, and what's working and what do people like. And so there were those. And then data warehousing and reporting systems that tabulate information in a way that you can do rapid cycle tests of change. You can rapidly try something and see what's working and what's not. So it gets at exactly what you were talking about, which is if new things are coming into place, we don't know if they're useful or not. And if we can get information, if we can test it in a small way and get information rapidly about whether or not it's useful and working, we can save a lot of money and time by, implementing what works and not implementing what doesn't. And there was no mechanism to do that in most health development projects. And so that's what we started to work on. We thought, we have these tools, and so we pulled into our program a couple of people who did some of the data analysis in architecture and reporting and dashboarding, and then we had people already on the assessments, and we began kind of putting those tools together. And through that process over the years, and began projects. So we began in Uganda, working in the Uganda Malaria Surveillance Program, pulling their data together in the Sentinel sites. They had a wonderful Sentinel site system where they were collecting good data at each site about malaria. Everybody who walked into the clinic, if they had a fever, they got a slide to see if it was malaria. So they're doing well on that, but they weren't getting that back fast enough to do anything. So it was taking about 18 months to clean and analyze. So we put that together into a data warehouse and wrote the metrics, through just using SQL scripts, so that they could get their data back in almost real time and help them dashboard it, and then help them with the process improvement system to get that to the clinic managers so that they could tackle the problems as they arose. So in one case, the person who ran the microscope, there was only one. His mother died, and he had to leave, and so there were no slides during the time he was gone. So they knew that fast enough to say, "Oh my gosh, we're not getting any slides. What's going on? Let's send another lab tech." And then they're getting good data back again. So those little things that trip you up, that make your data bad, you could quickly ameliorate. And so as we began doing that and other projects, we began to realize, what's really important here is that these base programs of data collection and data reporting, at least those need to be open platform, because data, just like you said, things change so quickly that things are obsolete so quickly that if they buy an off-the-shelf program, initially we started out just stringing together whatever they had, And often that was things that they were buying licensing agreements for, or should have been, and that they certainly couldn't get the update if they didn't at some point, and that's a lot of money. And so rather than doing that, if we could work on making an open platform basic data acquisition and reporting system, they could do a lot more testing of technologies as they began to come up without having to spend huge quantities of money and lose all of their grants in something that was obsolete a year later. So we began really trying to solidify the assessments and the outcomes, and especially the outcomes data collection and reporting systems. And that's been really, really amazingly helpful because now just like you said, there's so many tools out there, and you don't know what's going to be useful and what's not, and you can't keep up with all of that. But you can kind of say, what do I need? So that's actually one of the things we began doing, is helping with needs assessments.
Yeah.
People who are service providers in health don't know how to do a needs assessment or how to tell you what their requirements are. So we've tried to also standardize the process of expressing what your needs are, and that's been really helpful. And then you can begin to pull in tools and do rapid cycle tests of change and see what's useful and what's not, and then also maybe begin the process of investing a little more wisely in things that are open platform when possible, so that they can be upgraded rapidly. And then we also began the process of learning about in the tools that we were creating, how do they need to be flexible, and little things that you would never expect, like especially locations have different denominations of geographical areas. So they're divided up in parishes in Africa, in counties here, in districts in Bhutan. So we know we need to make the field for whatever the, there's village, and that's usually village or city or town. Then after that there's something bigger, and that needs to be flexible, and that kind of thing. So we began to learn where to put the
So you're talking about like the database structure,
the data collection, right? How do you make it easily transferable, scalable, upgradable, replicable, and what parts of it need to be personalized to the place you're working with, and what can actually be transferred place to place. And then as we were doing that, we also began to, for us it was all a learning process, we also began to realize that there are so many microcosms of working solutions, of people doing things that are incredibly intelligent, but nobody knows about it. So how do we also make this platform a tool to communicate working solutions from one area to another, assuming that they're culturally appropriate? And that's what we're doing now. So this year we have one group of students doing usability testing of a nutrition application with Paul Wise at Stanford down in Guatemala, where the malnutrition rate is incredibly high. About 40% of children in Guatemala show physical signs of malnutrition. And that, once you've got physical signs, the rate of malnutrition is incredibly high. And that was we built that based on their requirements, but we built it from our work with Bhutan. And then when Bhutan saw that, they said, we'd like that nutrition app in our data collection set of applications as well. So now we're iterating it back for Bhutan. And in that process, we're learning so much about what is and what isn't generalizable. And trying not to make any assumptions, but trying to make sure that the tools that we have can transfer. And then what we learned in Bhutan about what they're doing might be interesting and helpful to Guatemala, and what Guatemala is doing with the health educators might be interesting to Bhutan. And we're trying to ensure that those techniques are available, and we're learning how can we communicate those kinds of best practices or good practices. I don't like the word best practices because it makes it sound like you don't need to work anymore, that you've got it.
Right, yeah.
But so it's really neat. So I think our role is to set the stage for the integration of new technologies by providing at least a base set of tools that allow providers to access technology and to utilize technology to increase their efficiency. That's what we're really trying to do. And then from that, I think we'll all learn, I hope we'll all learn a great deal about how to shift tasks to computers that can be shifted and expand access to medical decision making.
Now, have you been able to find find companies that have been able to develop that technology and do it open source?
We have. So we have our, we've done it. So we have our about 5 different applications, 6 if you count the new nutrition application. We just haven't usability tested it.
Oh, okay.
So we've developed that, but there are ancillary technologies that we're beginning to work with partners to layer in. Like there's we use RFID cards for a patient identifier in some areas, and there's a company who has done that, has used RFID to make medical ID cards, and so they have a lot more functionalities that can be implemented into the cards, and they're so we're working with them to try to because we couldn't probably keep up with that technology and continue to iterate that piece of it. So we'd like to eventually make sure that there are partnerships with companies like that do a good job with pieces of the puzzle that we can then refer our partners to. And the more open platform, the better, but that's not always possible. So where possible, we're looking.
Yeah, because you mentioned open platform and open source a couple of times.
Yeah.
And companies that develop that technology are kind of difficult to find sometimes.
Yeah.
So it's common in the Linux world.
Yeah.
But Linux is an open platform operating system,
Yeah.
so you'll see a lot of community involvement for that. But when you're talking about other things like a database, or you're talking about mobile applications, it's not as prominent there.
Yeah. So we've built the base data collection and reporting system applications, but lots and lots of other technologies like whole blood testing, ancillary technologies or technologies that we'd want to incorporate into the point of care, like point of care diagnostics and things like that. We would want to be able to connect our service provider partners with an array of alternate partners that they could layer in that functionality to. There is a group called GSID, Global Solutions for Infectious Disease. So there are some groups that do that we've met and that we're beginning to connect with. But I think what's most important for us right now is to solidify the data collection and reporting systems. And even if it's reiterated better than we have it, at least to prove the concept has been really important. So that's what we've done in POEMS in Bhutan and Nepal. And fascinatingly, this system works for rangers as well as for health providers. So rangers are using the same types of tools to gather data on, instead of on patients, on animals and animal tracking. And so it's been fascinating to see how flexible, this kind of concept is to whoever needs to collect data and warehouse it and then look across data at relationships. And in the data world, there are open versions of, like there's MySQL, and there are certainly open versions of a lot of different software. But you do have to be careful. You're quite right. There are lots of things that are open that are still layers upon layers of errors, and so I think if we can do our best to look at what's simplest and most straightforward and most interoperable, at least in the first iteration, and knowing that will have to be retooled probably many times, and then ensure that the tools are retoolable.
Yeah. Now I know probably with other countries, probably the rules and regulations when it comes to healthcare information is not as strict as here in the United States. Here in the United States, we have to worry about HIPAA laws.
That's true. Yeah.
So is that kind of similar in the countries that you're working in, or not yet?
Yeah, not yet. But we try to. At least with HIPAA issues, it's not as complicated as you'd think, because you just have to put HIPAA boxes. Basically. Passcode boxes everywhere, that you're accessing the data. It's not very elegant. There are better ways to do it. But you are stuck here because of the HIPAA regulations in even system design. And then you're also here, you're trying to dip in and out of very closed, cumbersome systems like EMR systems often. So if you want to harvest information into a data warehouse from an EMR system, it's very, very difficult if it's a closed or multi-layered system. And so I think the systems are much simpler in the developing world, so the problems of data retrieval, harvesting, and data warehousing and reporting are much simpler. But it's very important to our group to make sure that some countries have laws that cover mobile technology and health data information and even mobile health information, but they're nascent, and so as much as possible we're trying to at least follow the HIPAA type regulations, and then even maybe go build more security in from there. And it's a hard question. I mean, one thing that's interesting is that so many ethical issues come up. If you think about things like HIV testing, if you just have a passcode box on an HIV result and that gets unlocked, and you get a bad dictator in who wants to get rid of all the expensive HIV patients, and they unlock it and find out who they are and go and quietly get rid of them all. I mean, that's terrifying to think that one could be putting that power into the hands of, of somebody. So we think about those things all the time, and we've drawn out, our security team has drawn out a number of different options for, important data like that really needs to be especially private. How do you put that into a different format that really can't be opened without 2 or 3 or 4 layers of security, or the patient themselves unlocking it? And there are definitely ways to do that, and it's just a matter of making sure that those are in place before that information goes into the system.
Yeah. Now, how are you doing the data collection? Are you just having somebody sit there and manually type everything in, or is it done automated, or do you have like a mobile application that you're scanning, or what? How exactly are you doing the data collection?
So there are a couple different applications, but all of them rely on the caregiver entering the data at the point of care into a tablet or a cell phone.
Oh, okay.
And then we do have a record application that records if they don't have time to enter while they're doing or if the looking at the tablet and entering data interrupts the relationship between the caregiver and the patient, then they can just push record and it'll record the whole interaction. And that's on the Android platform. We have one.
Does it automatically do a transcribe as well, or is it just do an audio?
No, that's a lot harder right now with the level of technology with voice recognition, where people's English might be a little bit different. It's a lot harder, so we don't have that, but that could certainly be built in when the voice recognition we've tried it, and it's just so cumbersome where people have different pronunciation of English. But I suspect that will change quickly because voice recognition software is changing so fast.
Yeah. In fact, later today I'm going to be talking to Nuance, which is they have a very impressive software package when it comes to voice recognition. And it's not just dictation. You can actually issue commands, and it opens up different pieces of the application.
Wow.
And you'll start giving a diagnosis for somebody, and you say prescribe this, and it'll automatically go and create the prescription and enter in the records and fill everything in for you all automatically.
Oh, that's wonderful. Yeah. We don't have that level of so the forms usually look like whatever the providers currently use. In Bhutan and in Nepal, they have kind of patient intake forms, and we've mimicked that in the Android application. And then there's a health provider, a health worker treatment protocols that are Ministry of Health approved, and those are the protocols that are in the application. So if the health worker types in a diagnosis or even a condition, it pulls up the list of potential diagnoses, and then from that the treatment options. So what's really neat is that they can take it to the market, or they can have it in their wallet or their bag, and they can meet a patient in the market, and the patient can talk about some symptoms, and right there they can pull up, the treatment protocol. And currently you may not have access to the treatment protocol when you're there with the patient. You may not know where it is, or it may have gotten lost, or somebody may have borrowed it, and oftentimes they're doing their best from memory from when you're training, and so to have those treatment protocols ready is amazing. It's amazing to see how empowering that is for the providers. It's their own treatment protocols right at their fingertips. Has just been amazing, and I think that's part of the power of technology. They have just 200 doctors in the whole country, so they really have limited access to medical resources, but having their diagnostic and treatment manuals at their fingertips gives them more access. And then if you extrapolate out, you can imagine another layer of World Health Organization treatment protocols, like key indicators of disease and treatment protocols being another level. You always want to have the local treatment guidelines first, and then second, another level, and then even reporting. You can do a lot more. You could really streamline the process of reporting out alarming symptoms and disease trends and things like that, because you can take de-identified data. You can have de-identified data automatically populate worldwide, data warehouses, where you're not actually giving any kind of patient ID, but just the piece of information of malaria was identified in this town, in this spot, with a positive test is possible. And so it's exciting to think about not just what we could do as a planet in tackling disease, but what the provider can do in improving their quality of care and access and understanding of issues, and even maybe the patients eventually.
Yeah, I think we've just really started scratching the surface on what can really be done.
Yeah.
And just started thinking about, well, how do we go about taking what we've been doing for many, many, many years and using some of the technology that we have available now and making things even better.
Yeah. And you're quite right. For some reason, there haven't been very many examples of utilizing this technology and demonstrating clear benefits in reduction in disease rates through use of mobile technology. I think there's really only been one. But there will be. I think there will be,
Well, I think part of the problem is, for one thing, people argue with me about this one comment, but the medical industry has basically stayed somewhat similar for thousands of years. You go into a doctor's office, they look at you, they examine, they prescribe, they figure out kind of what to do, and it kind of stays there at the doctor's office. And that's worked up until now, but now we have so much more available to us that now you got to really start thinking differently than what you have for thousands and thousands of years. It's really stayed kind of similar, the way the doctors work for thousands of years. Now all of a sudden it's starting to change a little bit. So you're having to go against that. The other thing, I think, is that if a doctor makes a mistake, somebody could die. So that's why I think the medical technology in the medical field is a little bit behind the rest of the world, because they're worried about making a mistake. You cannot make a mistake there.
Here they're worried. I don't think that fear exists as much in many low resource areas.
Right. Yeah. They're whatever you can do that might help, they're willing to do. I was talking to somebody the other day, and they were saying that a lot of the innovation that's here in the United States, a lot more is moving forward, and actually in the veterinary industry, and it's transferring over to the people industry, because nobody's going to be worried about your dog's medical records getting out there and people taking advantage of that. Nobody's really too worried about that. So they're doing a lot of that research on animals and using technology and gathering data. I'm not talking about doing medical experiments on I'm talking about mostly data collection and analyzing that. That's really where that type of innovation.
I think exactly. I think the issue isn't it's more that there's a tabula rasa. There's more of a tabula rasa in certain low resource areas, so that you can innovate and you can develop streamlined systems and then see what's working and what's not. And it's just more difficult in some areas here because of the layers of code, that have been built one upon the other, and things like that, and all of the laws and rules, all of which are really, really critical. But the other thing that strikes me more and more as we work in these different areas is that there's such insight that comes from the efforts that and the care that is being given at the point of care in low resource areas. I mean, we forget the art of medicine sometimes here because we have so many tests at our fingertips, and when you don't have a lab that you can easily access, there's a lot more sort of diagnosis based on the information that you have, and kind of learning how to treat things based without feedback, with strategies and skills that make sense, but that aren't being based on on information that you have access to all of the time. And then also there are people are putting together strategies that are incredibly intelligent and work very, very well that nobody knows about because they're in this low resource area. One example, there was a community that had developed groups of citizens that were ranging out looking for poachers and reporting back quietly. They would just go out and kind of survey, looking like they were looking at their crops, and they were reporting back using cell phones when they saw somebody who might be a poacher. And this was in Nepal near Chitwan Forest, where they were losing so many animals. They only had 3,500 tigers left and not too many elephants. And the village had gotten together and said, let's do this. We'll have these foot patrols and they'll go out. And because poachers are dangerous, they didn't want to look like they were really hunting for poachers. So we'll sort of just, use our usual kind of herding and farming work to cloak what we're doing, and then we'll report back. And they had this whole phone system set up, and they began in the whole year following the implementation of that. They had no poaching in the whole year in in their district, in their region. That village had done that. That town had done that all by themselves, and nobody knew. It was a very, very small village, and they'd used technology, cell phones, to develop their own little system of reporting, and that had gotten to the rangers, and the rangers had been able to find the poachers, and the poachers hadn't gotten any animals, and it was really working. And similarly with barefoot doctors and community health workers, there are things that they're doing that nobody knows about that we can begin to learn about and report. And that's, I think, also as exciting, because we can make better use of resources if we're not relying so much on high-cost tools. And we don't need to all of the time. I think we do it a lot more than we need to here. And sometimes it's to the detriment of the patient rather than the benefit. So that's exciting too.
Okay, well, thank you.
Thank you.
Yeah.